Good morning, good afternoon, everybody. I'd like to introduce Dr. Scott Hagan. He is the medical director of the Seattle VA Primary Care Clinic and assistant professor at the University of Washington Department of Medicine. He works with Dr. Karen Nelson and Dr. Ashok Reddy of the Primary Care Analytics team to study the upcoming VHA EHR transition and its impact on patient safety and quality care. Thank you very much for presenting today. Dr. Hagan, can I turn it over to you?
Thank you so much, and thank you for the opportunity to present this cyber seminar. I'll go ahead and get started. I'd like to start with a poll question just to get a sense of people's background. I think the poll question should pop up in the chat at the right of what your background is. I know this is not an exhaustive list, and perhaps these options do not apply, but just curious what type of attendees we have today.
And that poll question is open to the attendees, and we'll wait for it to slow down before I close the poll. Responses are coming in, and I'm going to go ahead, and it's starting to slow down, so I'm going to go ahead and close that poll. And here are the poll results. So you could see we have 53% that say they're clinicians, 12% statistician, 0% as computer scientists or programmers, 24% health services researchers. We have 29% clinical leaders, and no one said they're the research program lead. And back to you.
All right, thanks so much. Well, thanks again for attending. I have no financial conflicts of interest. I'd like to acknowledge my, I'd like to just say a word about my personal background. So I work out of the VA Puget Sound. I work with the Seattle Primary Care Analytics team. My mentors there are Ashok Reddy and Karen Nelson. And I'm the director of the Seattle VA Primary Care Clinic. We serve over 18,000 veterans in VA Puget Sound. I'm interested in patient safety, EHR modernization or transition of records, which is set to occur over the coming years, and also electronic quality measures. I do not have a background in computer science, programming. I don't know how to use SQL. I know what the CDW does, but I don't know how to work within it. So just know that if questions come up there, I may not be able to answer them. So some of my collaborators in PCAT in Seattle, Shelley Weed is a research statistician who's been very important in the development of the project I'll talk about in the latter half of this presentation. Ashok and Kari that I've already mentioned. Steph Deeds is the director of the Primary Care Innovations Lab which is within PCAT. And Ryan Laundrie is a programmer and research assistant on this project. And then outside of VA Puget Sound, Dr. Hardeep Singh, who's based in Houston at Baylor, and the Michael E. DeBakey VA is also involved in this work. So thank you to my collaborators. The objectives of this talk are to define electronic clinical quality measures, or EQM, and electronic triggers, or E-triggers, to review the challenge of view alerts and test result follow-up and communication within the VA, to review some recent examples of E-triggers that pertain to patient safety for outpatient care, and to describe a project of hyperkalemia test results as an example of a novel E-trigger that could function as a quality measure. And then finally to explore, comment on future directions of text search E-triggers to support outpatient safety. So just as background, US and other national, regional, global governing bodies of healthcare and VA want care quality and outpatient safety to be tracked. I think the most prominent example of this would be the HEDIS metrics, the Healthcare Effectiveness Data and Information Set. That is managed and developed by the national, oh gosh, I don't know what the acronym stands for, NCQA, which reports to CMS to develop these metrics. And then those metrics are required to be reported by healthcare facilities that contract with CMS. And the VA is beholden to those measures as well. Some common HEDIS measures that I'm not going to read all of these, but some examples, some of which pertain to very much to primary care would be like diabetes control, care control, like the percentage of A1Cs below 9%, or blood pressure control for patients with diabetes, hypertension control in general, medication adherence, medication reconciliation. There's a lot of HEDIS measures. And to measure HEDIS related metrics, there's basically two options that VA uses for this. Option one is to pay a staff of nurse coordinators at every VA division to review a small random sample of the measures that would pertain to each individual HEDIS metric. That's called the External Peer Review Program, or EPRP, which VA has. And the pros are that in theory it's accurate. It's direct chart review of a sample of cases, and it can be implemented across a broad scope of measures because it's chart review. And the cons are that's expensive to implement. The scale is small. The numbers are a small random sample in any time period. And it is not real-time data. It's time restricted by the reporting intervals that those nurse coordinators are needing to meet on a monthly or quarterly schedule. The second option is to use objective data elements in the corporate data warehouse or by other means for quality measures. And VA calls this EQM, or electronic quality measures. There's a more general term, I think, that is trending towards being favored outside of VA, called electronic clinical quality measures. We call it EQM. It's a program that is starting to replace some EPRP measures or duplicate some of them. And the pros that it's potentially large scale. For example, running all patients who are defined by a cohort to have diabetes, and seeing what percentage of those patients that are enrolled in VA care have an A1C less than 9% or checked in the last 12 months. The cons of this would be that it would ideally, each of these measures that are done electronically should have some type of data validation of comparison to standardized chart review. And it's limited by the data elements that they're trying to look at. So things like diabetes, where it's a very clear the quality measure used being the A1C percentage and the labs. That would be the same type of lab at any VA facility. That's more simple than some more complex measures, like seeing if a provider followed up on a test result. So, oops. Okay, there we go. So those are kind of the two options. And I'll just say quality measures in general for outpatient safety are pretty rare within the VA's big menu of quality measures that we track. So these things are monitored by the Office of Performance Measurements that oversees both performance measurements, care quality and patient safety, and also SHAP, or patient satisfaction scores. And so some examples of outpatient EQMs or EPRP measures that focus on quality would be things like diabetes control, hypertension control, behavioral health screenings like PTSD and depression screenings occurring annually, things like different cancer screenings such as colon cancer, cervical cancer screening, tobacco use screening. So there's a number of measures that would fall under that bucket. Depending on how you're defining patient safety, which is beyond the scope of this talk, the measures that look at patient safety in the outpatient setting are more limited. So in my view of the EQM and EPR measures, there's really two that focus on outpatient patient safety, and those would be the CTR, which stands for I think, communication of test results. Those measures, there's 4 of them. I'll talk about them in more detail in the coming slides. And then the MREC measures. These are all have short lowercase acronyms for them, as you're seeing there. But the MREC measures looking at medication reconciliation. So to talk more about the CTR measures, first I'll just say that managing results, as in primary care, I can speak to this, is difficult. This is a screenshot. It's taken from a paper written by Dr. Singh's group in 2013 as an example of what a provider who's ordering things and referring patients across a panel might come back to when they open up their chart each morning. You'll have a bunch of different patient results. This is what the provider sees when they open CPRS, that there's this window at the bottom that is the notification section. You can organize these by the patient or by the urgency of the results. Some are deemed high urgency, unclear how the criteria for that is set. For example, this one's listed as urgency high for a medication nearing expiration. That might be a Tylenol order that occurred a year ago and is not something necessarily that the patient is requesting a refill on. There might be alerts that, hey, your patient got scheduled for that thing you referred them to for an echo or an orthopedics consult. And then mixed in with that might be normal and abnormal labs, and normal microalbumin, an abnormal basic metabolic panel, an abnormal troponin. Yikes, want to see that as an outpatient. And then unsigned notes or notes needing co-signature. Those are all lumped in one place in CPRS. And Dr. Singh's team has did a national survey of providers a few years ago about their opinions on the management of test results and VHA, and ask a number of items of what they think is challenging or made easy by the computer software we use to follow up on test results. For example, when on a Likert scale, CPRS has convenient features for notifying patients of test results. Only 24% of providers in this sample agreed. Follows up on all alert notifications. 12% disagreed on that. And then I think one of the most concerning in this table 3 would be alert notification system in CPRS makes it possible for providers to miss test results. That's 55% said agree or strongly agree. And then just to go to a couple of other tables that I found interesting in here would be that the number of alerts exceeds what the provider can effectively manage. Almost 70% said yes. Receiving too many alerts to easily focus on the most important ones also strongly agrees. 5% said that they did not consistently notify patients of abnormal test results. And there's concerns, something I didn't mention in that slide just on the provider alerts. When providers are out of office, they would surrogate their alert results to another provider, and there's concerns about how that system can create patient safety gaps. And then finally, there's a series of questions they asked about what providers would like to see improved in CPRS regarding test result communication. I think the most striking strongly agrees was, I would like to have a back button in CPRS to retrieve the prior window. So back here, when you're a provider and you're clicking on this result for for this abnormal troponin, say, and you open that, but then you might get distracted by something else and need to click into another veteran's chart. That result goes away, and there's no way to get it back besides knowing if you remember the patient or their name, last name, last four. You could get to it that way. But that absence of a back button or a second confirmation of the processing is what some providers in this study thought contributed to missed results. And also, the other interesting thing I found here was that I would like to receive feedback about my performance related to follow-up of high priority alert notifications. So providers wanting an additional system to be able to know when they've missed important results. The VA has a directive on the communication of test results. It's called Directive 1088, which is a long document, but the upshot is that in VA outpatient, if you order a test and it's a normal result, it should be followed up within 14 calendar days. If it's an abnormal result, meaning one that might require some kind of action, it should be followed up within 7 calendar days. And another part of the directive is that the steps taken to follow up the results should be documented by some way in CPRS. They should be discoverable by someone else who would click into that chart to know whether you have followed up that result. So this measure, CTR22, tries to look at the communication of test results. It's part of the SAIL metrics. Here's the VA Puget Sound's SAIL metrics report. You may have seen reports like this before. Evidently, my facility is in the kind of middle to, I think, second quartile of performance on this. So what are these CTR measures? What do they do? These were a series of measures. There's 4 of them that were started in 2018. There's an older version of this that got updated then. The 22 measure gets dumped into SAIL. I'll talk about what that is, but it's looking at a bundle of commonly ordered tests and studies. So a FIT test is a colon cancer screening test, hepatitis C screening, HIV screening, AFP is a liver cancer screening test for those with liver disease, a DEXA scan for bone density, mammograms, PAP and HPV screening for a cervical cancer screening, and then CT scans and chest x-ray results. Those are the eligible tests that might get reviewed to see if results were followed up, and this is done quarterly. So how is the sample that each nurse coordinator at each VA facility, how is that sample taken? Basically, the results that I mentioned in that past slide are filtered to only those results ordered in an outpatient ordering location. And then EPRP has this sampling criteria that they use for all their outpatient cohorts. And the key thing is they're trying to identify a group of veterans that are experiencing continuity within the VA, not necessarily someone who might have showed up for one appointment and then never had an appointment before or after that facility. So it's appointments during the study month in a Nexus designated clinic. Those are generally clinics where there's a clinician visit that's occurring, whether it's primary care or specialty care. Also, they've had an encounter 13 to 24 months previous to that, suggesting continuity, and then and an encounter within the past 12 months with a provider. And then they exclude for these cohorts inpatient, urgent care, same-day procedure testing, or community care testing. That's how the samples are defined for these. And for the CTR measures, I'm sorry I flipped the 7 and 14 day here, but I mentioned there's CTR 20, 21, 22, 23. So 20 is normal test results, just the follow-up of normal test results. So the reviewer is looking that the clinician had followed up that test result within 14 days by chart review. CTR 21 is abnormal test results, that those have been followed up within 7 days. CTR 22 is the combination of both normal and abnormal test results, just the aggregate of the first two. And then 23 is that any result has been followed up within 30 days, kind of a lower bar for follow-up interval. And what qualifies as actual follow-up would be, is there any documentation, either through an in-person note, a virtual encounter, a secure message, a standard results letter, that follow-up occurred? And these are results that you can find. There's this, if you search in the RAMP, the VA measures portal, you can find this. If you search combined measure master, lists all these different HEDIS metrics. Anyone can look at this data. So for example, these 20 to 23 CTR measures in the fiscal year 2021. Just get my pointer here. For the normal test results, the total number that were reviewed at all facilities in that fiscal year were 16,000, 7,000 abnormal results. Not sure why they didn't lump these together for the combination, and then the 30 days would be 23,000. But you see here, if you just focus on the yearly results, that depending on which measure you're using, somewhere between 10 to 25% of results were not followed up. And you see, if you look at an individual division, so VA Puget Sound, which serves about 80,000 veterans, has, I think we have a total of like 10 different clinics, 2 med center campuses, and I think 8 CBOCs. In any quarter, there's very small numbers that are sampled in this cohort. And the reports say, they have a big, like in bold in the measure report, please exercise caution when analyzing data with low denominators. In other words, it would be hard to interpret this result with close to 10 in any quarter. And you see that, by the way, the result bounces around so much between quarters. So my summary of the CTR measure would be that it's the VA's effort for as a safety measure for test results communication in the outpatient setting. It's the only outpatient safety measure in the SAIL reports, and I didn't say this, but SAIL is the system that VA uses to try to track the care and safety, or the quality and safety of care at each VA division or network. The denominators in any quarter are too low often to interpret the data, but the scores suggest there are a significant percentage of missed or delayed test results. And these measures do not include the most commonly ordered tests in primary care, which are probably, and I didn't look at the literature on this, but I would guess that that might be things like a basic metabolic panel, a hemoglobin A1C, and a lipid panel. And then finally, this is a manual measure. This is a nurse coordinator at each VA receiving a sample of abnormal test results, looking into each chart of the patient and trying to confirm whether or not the communication occurred, rather than an electronic quality measure, an automatic quality measure. Dr. Zamolzek, who's part of the Houston VA group that Hardeep Singh leads, is recently, and JGM did a qualitative study on providers, asking the question, why are outpatient results getting missed? What are the reasons that result follow-up is so difficult? And I'm sorry that these words are so small, but I wanted to point people's attention to the risk areas that are commonly identified in these participants of the clinicians that were interviewed for this, the primary care clinicians. One big bucket is trainees, the common problem that trainees at academic medical center campuses for VA come and go on their rotations, and when they rotate off service, those results might not get followed up. The incidental findings on imaging that might be buried within a report and missed on a quick scan of the impression. The lack of good EHR and related tracking systems for abnormal results, that, you know, the back button, and the fact that you don't have a back button and then you don't have a way to know if you missed something, that it was missed and remains missed. Lack of updated patient or provider contact information, challenges in referral for consultation and testing of follow-up. You know, the question of this result was requested by a specialist to be ordered in order for a consult to occur. I am having trouble interpreting this, but the specialist is not helping with the interpretation either, as an example. The problem of surrogates more generally, and the lack of clarity regarding the clinician responsible for pending lab test results. Let me just look at the chat for a second. Agree if I open alert, but then accidentally close. There's no way to get back. That's a systems issue, absolutely. Are they considering the facilities that have automated lab letter results? So yeah, any standard, so-called standard letter result counts as communication. I think one of the challenges of these manual chart reviews, they do have criteria of what constitutes acceptable follow-up, but whether the follow-up actions were clinically appropriate is a bit beyond the scope of the individual nurse coordinators to determine. It's more that whether the follow-up effort was made. Okay. So, and then the second part of this qualitative study was to ask the participants, what do you think would make things better? And there's things like designating, better systems with trainees for who's responsible for follow-up, creating surrogates. Now in VA, it's an expectation that any trainee has a backup reviewer assigned, such that if an alert is not open within 5 days, that alert gets sent to the supervisor, and that surrogate designation often does not occur. Having more clear communication from the interpreting specialists on incidental findings and imaging, but the most consistent theme was trying to have better EHR systems for tracking of results, both education on the best use of CPRS and how to process alerts effectively, but also, one example here, send an alert to department leadership if a provider falls behind in taking care of the set number of alerts. Standardized process where all providers can take care of their view alerts in the same way. Weekly monitoring of alerts or unsigned notes. Some of these systems don't really exist for clinical leaders to help clinicians make sure that they're staying ahead of missed results. Okay, I'm going to move on. So one opportunity I think in assisting with identifying abnormal test results and both monitoring that and feeding that back to clinicians would be through the use of electronic or e-triggers. And e-triggers globally would be defined as tools that are trying to mine some clinical or administrative data within a database to identify the signals for adverse events. And they do that by leveraging an automated search of that database, which ideally would minimize the need for human review of each of these. And usually that's done by using structured data, a specific follow-up action that's occurred, such as a referral. Your PSA test is elevated. Was there a referral to urology or a repeat test that occurred, being an example? The IHI, the Institute for Healthcare Improvement, has this global trigger toolkit that's primarily focused on inpatient, excuse the spelling error, examples of this. But VHA has been a leader in trying to develop outpatient e-triggers. I'm going to review a few examples here. These are all done by the Houston VA group led by Hardeep Singh, and are made possible by our corporate data warehouse. Has the audit been done with specialty care providers? Yes, so that measure applies to all outpatient care. It's not specific to primary care. And all, not held to the same standards for the directive, and unclear, what the expectations and the and how well people are held to these standards are. I'll mention an example of that in the project that I worked on. So let me just show a few examples of e-triggers that have been developed. And so one is about elevated TSH results, or suggestive of hypothyroidism. And this was a trigger where they looked into the CDW for examples of an outpatient TSH result that was above 10. They tried to exclude all inpatient examples or people that had already known previously untreated hypothyroidism. So, and that were already on some kind of oral thyroid therapy, i.e. this is someone who has a diagnosis of hypothyroidism. The clinician's checking to make sure the dose of the medication is in the right range and that the TSH is in the normal range, and whether that there's actual follow-up on the result. And the trigger that they used in this is for those examples, was there either a new prescription, i.e. a change in the dose of the thyroid medicine, or a repeat TSH level within 60 days if the clinician decided not to adjust the dose. And the upshot is they ran this trigger, and then they did chart review of positive triggers to see how many of those were actually not followed up by these actions. And they were able to identify a lot of cases in the trigger where it suggested that appropriate follow-up did not occur, where it was in fact the case that no follow-up occurred 60% of the time. Is the positive predictive value of this e-trigger. A lot of the false positives had to do with either that the clinician did discuss the result. It's just that it was concluded that the patient was not taking the medication as instructed, either due to adherence or taking the wrong prescription or something like this. That was kind of the biggest example. And they acknowledge that because they're using actions in the chart, like a change in dose or a repeat thyroid test, that they might be missing this part in the chart where there's documentation of why those changes did not occur, and that future work could use natural language processing methods or text search of the chart in some kind of sophisticated way to try to increase the predictive value. And this same group at the Houston VA has tried to validate measures or has validated measures on cancer, different types of cancer screening. So they did this big study in BMJ quality and safety on 4 different criteria. So one would be a prostate cancer trigger where there's an outpatient PSA result that was elevated without a prior known diagnosis of prostate cancer or biopsy within the last 2 years. And the trigger, what they're looking for in the CDW is, did a repeat PSA or urology consultation or prostate biopsy occur? And then 3 other examples related to colon cancer. The fecal occult blood test, the most commonly ordered yearly stool test to try to detect colon cancer. If that's positive, the next test is a colonoscopy. So positive results, was a colonoscopy performed within 60 days after the red flag criteria for those who did not have a prior colonoscopy, and there's some other exclusion. Or did someone have identified iron deficiency, not just deficiency, but anemia? And patients age 40 to 75, ideally that should trigger a testing for colon cancer by a colonoscopy. Was a colonoscopy performed within 60 days after the red flag criteria met? Or was there chart documentation by an ICD code of a diagnosis of hematochezia? And if so, with some reasonable exclusion criteria, was a colonoscopy performed? So they ran a validation of this where they ran the trigger. They looked at the trigger positive results. Trigger positive meaning the trigger suggests that in those charts, follow-up did not occur according to that. And then a gold standard chart review was done to look and see what actually happened. And the positive predictive value was in the kind of 58 to 70% range, depending on which of these tests were done. So pretty good at identifying a big chunk of patients who did not receive the expected follow-up referrals, testing. And then one more example in this vein would be on radiology results or abnormal chest X-ray or chest CT scan results, in which the radiologist flagged suspicious for malignancy, i.e. this needs to, should be referred for further evaluation, further testing. And with some exclusion, the expected follow-up would be either some kind of pulmonary or thoracic surgery or tumor board or some kind of referral to a specialist or repeat test of some type of the chest X-ray or chest CT or a procedure like a biopsy. For this type of trigger, the positive predictive value was 61%. Very sensitive for detecting the miss, but I think like with these other results, we're not talking about positive predictive values, above 90%. There's a fair number if you look in these that did have some kind of appropriate follow-up, and that might have been things like they had prior imaging and it was actually stable from that, or the patient elected not to undergo repeat testing, or other examples. So, so those are some examples of the e-triggers that exist currently, which use clinical actions to follow up testing or medication changes. And the strengths are that they have research validation. That the groups that the Houston group for each of these has run a gold standard chart review type of test to see how good are these these working. They're scalable in that it's a query to CDW that's run and can spit out the results, and they're mining clinically meaningful information, test results for things suggesting cancer. The main weakness is that the positive predictive value is not high. It's in the kind of moderate range, and it doesn't look at more commonly ordered test results in the outpatient setting, which would give a larger amount of numbers to be able to really monitor, use it as a measure for a facility for how well things are occurring. Which is kind of a similar problem, I think, to the EPRP data, the CTR measure that I talked about. Just to answer in the chat, if informatics is working on a way to remedy that problem, I think what the powers that be would maybe say is that the transition to a new electronic health record that does have more features like that is the solution that VA is trying to take right now. Although these e-triggers might be a way to try to identify some ways to get yeah. So depending on which site you're at, that might be 6 months, 6 years. So that's a big problem. So what our group wanted to do is to try to look at a more commonly ordered lab test in the primary care setting. And the one we selected was an elevated serum potassium level, or hyperkalemia, which we know raises risks for mortality. I'll show a slide in a second about that. And that there are actions that can be taken, such as medication adjustments that can lower the potassium level before reaching more dangerous level. And VA potassium, or not in VA, just generally a potassium of 5.5 to 5.9 is considered moderately elevated. And most would probably agree some kind of action or recommendation should be done to try to modify that in most patients, but is not like a critical potassium above 6, for example. And in most VAs, that would be a clinician. A clinician is paged to the results same day by the lab. Hey, you need to follow this up. And often that might trigger like a same day ER visit, or a call same day to get a lab test the next day or something like this, much more urgent. So the goal of this was to try to create a text search e-trigger to identify delayed communication of outpatient moderate hyperkalemia results. Just to show, there's been outpatient studies of baseline serum potassium levels, that the higher your potassium level gets above that 5.5 range, especially if you have diabetes or heart failure, chronic kidney disease, or all of them combined, the higher your risks of mortality in the coming. This cohort was over an 18-month period. So if you had a potassium on any result of 7, you have a 50% mortality risk in the coming 18 months. The VA has, by the way, for critical labs, recommendations about what is defined as a critical lab. So what is it? The potassium level above 6 or less than 2.5, and there's other examples here: platelets below 20, above 1,000. These are trying to identify people that really should be contacted right away to try to get some action or change to occur, but miss a big cohort of people that have importantly abnormal results that should have some less acute action that should occur within the coming days to weeks. So I'll talk about how we tried to pull this sample, but the tool that we used to try to develop an e-trigger for this was this tool previously developed. Ryan Laundrie, who works at VA here, was part of developing this tool called the Veterans Indexed Search Analysis, or VISA tool. And it takes data from Vinci or CDW is, and you can pull a query of text notes, and those notes come in an index, so a series of files that have documents in them. And then what the software allows is to search all those notes for the word strings that are of interest to your research. And so terms or concepts or field values can be used to develop some kind of algorithm to try to define what you're searching for. So it has more advanced natural language processing tools or just simple search query tools, and makes it easy to review a large number of charts quickly to develop a query. And so like the example that they talk about in this reference was to identify in the chart documentation about a veteran suicidal ideation, and to identify missed follow-up, ideally as a way to identify whether that patient had appropriate follow-up down the road. So with using that tool, what we did was to pull a random sample using that same criteria I talked about before of outpatients who have continuity at VA, who have a test ordered by an outpatient provider, who aren't, that wasn't done as an inpatient, that have a potassium result that's elevated but not critically elevated. And then we took all the notes in CPRS, the text integration utility documents, following each test result at 28 days after the result, and ran it through VISA to try to identify search queries that look for an attempt at communication of the result within 20 days. We kept running that and compared it to a standard chart review of just looking in the notes to see was follow-up action actually taken. And once a query was finally stabilized, one that we thought was performing quite well, we did a validation of this query with a random sample of charts using the gold standard of chart review. So, our SQL query looked like this. There's a where clause in it with a bunch of operators that are, like or not like operators trying to, for example, look for potassium or words that look like potassium, hyper K, K positive, but also filtering out things like amoxiclav K is a thing that would be a positive hit that is talking about Augmentin, the trade name for that, or vitamin K, or potassium chloride, talking about like a prescription without explicitly talking about the result. So this is the gobbledygook that was, that we settled on, that seemed to be performing well. And we took over a 3.5-year period all moderately elevated outpatient test results in VHA over 2018 to 2021. There are 238,000 examples of them. And then we filtered out results of patients who had a diagnosis of end-stage renal disease, i.e. had dialysis dependence. In part because those patients often have the test result done and then an action communicated or taken on it same day in the dialysis unit. It's kind of hard to interpret whether the results were, whether communication occurred or not. And then filtered out, excuse me, this is all VA results, filtered out the inpatient or urgent care ER results. And then duplicate labs, like was a repeat lab ordered later in the day. So we got down to 66,000 results over that period. And then a random sample was taken from all VAs. And a gold standard chart review was done on all those charts to see was there documented follow-up that occurred. We did not aim to see if to determine whether it's appropriate, like, you know, would I have done that action, or you know, was it within a standard of care for what you'd expect for a clinician to follow up the result, i.e. like a repeat level or a change in a medication or something else. It's just, was the result communicated? Was it, there's documentation of the communication. And of those 456, 66 were trigger positive, that the trigger suggested there's no follow-up. 62 of those were true positives, where there's truly nothing in the gold standard chart review that that suggested follow-up occurred. So the positive predictive value was 94%. The sensitivity was a bit lower. Copy-paste errors were the primary source of the false positive. There was a note, maybe in a different clinic, that has a boilerplate lab listed somewhere down further in the note, but there's nothing in the note text itself that talked about the management of that abnormal recent test result. That was the most common reason for that, you know, the PPV not being 100%. I didn't mention, I assume that a question about renal function related to that first slide. Yes, if your renal function's abnormal, the more it's abnormal with the hyperkalemia, the risk goes up even more. But our study didn't pay attention to renal function itself. We did look at chronic kidney disease. And then we did some provider and patient demographic data that was run about, you know, those who are trigger positive, where the e-trigger suggested there's no follow-up, versus trigger negative, where there are significant differences in, you know, patient demographics, comorbidities like chronic kidney diseases in there, congestive heart failure, diabetes, hypertension. Fortunately for this bucket, you know, that what was significantly different for some of these, like CHF or complicated diabetes or hypertension, was that those patients were more likely to have, by the trigger at least, evidence of chart follow-up. The, I guess, disheartening one was that primary care providers were significantly, if primary care ordered the lab, is significantly more likely to be in the trigger positive bucket there. The moderate hyperkalemia e-trigger, the conclusion being it's a common test result during that study period. I mentioned it was something like 66,000 patients over a 3.5-year period. If I were to go back many slides and talk about the CTR data, that trumps any of that big bundle, is more than twice as large for, you know, over a quarterly sample than any of those measures for national VA. So it's a much larger sample, and it's all patients with abnormal test results, you know, with those filters that they're outpatients and they're not on dialysis, and a couple others. The trigger had moderate sensitivity. There were some charts where it's, and that's the charts with false negatives, where the patient did not have appropriate follow-up, even though the trigger suggested that it was. That was the copy-paste error issue related to the sensitivity. But we think our PPV was better than these e-triggers that look at clinical actions, because it's using the text search in the notes, which is trying to get at, sometimes clinicians don't refer for like a repeat test or a referral to a specialty because there's some special situation there that might be charted. But the flip side of that is that this type of trigger doesn't look at whether follow-up action was appropriately taken, or whether some undocumented actions occurred in the chart. And finally, tests ordered by primary care in this sample were significantly less likely to have the adequate follow-up. So the future directions of this work is that a trigger like this could be expanded to things beyond just hyperkalemia, to a larger list of commonly ordered test results, other components of the basic metabolic panel or CBC, for example, to develop a bundle that could be run just as an algorithm in real time at any VA with a very large sample. That could be a more meaningful measure because of the high numbers, and that's validated in a way that I think is maybe improves on the CTR measure that we have now. Ideally, the future scope of this work would be to develop a larger bundle like that, and then to use that bundle to make a measure that facilities could use to monitor transitions in care. For example, what happens when a facility transitions to our new health record as far as test result communication and follow-up. That was our original interest in developing this trigger, is to use that to then apply it to study EHR transitions and the safety events that might occur. But also beyond just a safety measure, it could be used to give feedback to individual clinicians. If there's an adequate sample size down to a clinician level, it could be used for directed feedback to clinicians, or used by the clinicians themselves to follow up the test results that hadn't been communicated. So that's the end of my talk. Thank you so much for attending this talk, and I'll take any questions there in the chat.
It looks like you've been answering the questions as you were going along. So currently we don't have anything queued up, but do you have any closing remarks?
I think that it is, I guess I would just say it's exciting to me that, we can start to use this natural language processing and text searching for something clinically meaningful in primary care. And I think there's a lot of work that can be done in this vein, not just on test result communication, but all other kinds of monitoring of outpatient safety. I think even could have applications of things like medication reconciliation, or discrepant orders, or different things. So I think the opportunities are endless. I like many who are interested in the transition to a new health record have questions about what that data is going to look like in the new health system, and how we'll be able to compare that data. So that's a real question mark, but we'll know soon.
Well, thank you very much for taking the time to prepare and present today. I do not see any other questions in the queue. So I want to thank the attendees for joining us for today's session. And we do have a comment that it was an excellent talk and learned a lot. And when I close this meeting, you'll be prompted with the survey form. Please take a few moments to fill that out. We really do count and appreciate your feedback. Have a great day.
Thank you.
Thank you.